Hello. My name is David Chrimes. I am the Business Development Director for Cooper Genomics within the Fertility and Genomics part of Cooper. I have been working in PGT, so embryo testing, since 2008. So I've seen a lot of changes, how the technology has come alive over the years. I am a molecular biologist by training, so I'm approaching this a lot from a molecular biology side, but it is a very important and key subject. So what I'm talking about today is why you may want to offer PGT-A because of the ability of it to reduce the trauma of miscarriage. So really, today's presentation is all around one of the applications of PGT around one of the fundamental areas of fertility and pregnancy, which is miscarriage. So today we'll be covering 4 major topics: the overview of how miscarriage and maternal age are linked, look at the impact of miscarriage from a psychological point of view for the patients involved. We will then quickly touch on PGT overview, just remind ourselves of the technology, and then explain why this is so important in the reduction of miscarriage, and then take us from the theory of why PGT-A is important for the reduction of miscarriage to actually there is significant evidence now in how this is actually seen in the field and in clinics. So let's look at miscarriage and maternal age. So one thing that we've known, and we've known it for many years, and this is a paper back even to 2007, but we know that in 50 to 70% of pregnancies that result in a spontaneous loss have some kind of cytogenetic abnormality. And when we say cytogenetic, what we really mean is chromosomal abnormality. So a human genome is made up of 24 pairs of chromosomes. You have the autosome and then you have your sex chromosomes. So if you're a female, XX, if you're male, XY. So what you have are your autosomal chromosomes, which are shared between both males and females, and they account for 60% of those product conceptions or the spontaneous losses of pregnancy. Monosomy X, also known as Turner syndrome, not all Turner syndrome make it to live birth, and it seems that if you have a monosomy X, then a lot of those will also miscarry. And polyploidy is where you have more than or less of the exact number of chromosomes. So it could be a haploidy, so you only have 1 copy of the genome, not 2, or you could have 3 or 4 copies. But nonetheless, these are all detectable, and they're even detectable in the embryos. So we can test all of these conditions before we put the embryo back in IVF. And we've been doing this for many years. And what we have now established, as we now do day 5, day 6, even day 7 trophectoderm biopsy, it is shown to be very robust, and of those embryos available for testing, i.e. those that have made it through to day 5, 6, 7, even in egg donors, 25% of those embryos are aneuploid, so the blue bars. Yes, the majority are euploid, but you still have 25% of them being aneuploid. And then you have a curve or a line, which we've seen many times over the years. As the maternal age increases, you get a dramatic drop off in the number of euploid embryos available and the corresponding large increase in the number of aneuploid embryos. And really the tipping point is around the maternal age of around 35. Under 35, half the embryos are euploid. Over 35, less than half are euploid. And so what this means is if we look at how pregnancies progress as maternal age increases, we have this classic chart in that As the maternal age increases, the amount of aneuploidy, which I've previously shown, we've seen to massively increase. This is driving the miscarriage rate to follow the same trend as the aneuploidy. As I've just explained, aneuploidy is the leading cause of miscarriage. And what that results in is a massive reduction in the live birth rate as the maternal age increases, particularly once we reach past the age of 35. If we consider some fertility data, so this just as an example, I've used the UK HFEA data, but this is very consistent with what we see across all of the developed world these days, is an increase in maternal age of patients. And so what we see is, as we go from 1991 through to 2017, that the average age of an IVF patient has been increasing. But what we also see now is that over half the patients as of 2017, and I'm sure the trend has continued and in fact probably increased, over half the patients being treated in IVF have a maternal age of over 35. So very much at the at-risk group when it comes to elevated risk of miscarriage. So we may consider that we know that miscarriage increases with age. We can counsel patients accordingly and tell them to perhaps even expect a higher chance of failure and a higher risk of miscarriage. And at some level, we are fulfilling our duty by doing this, absolutely. However, it is very hard to understand as an individual what impact miscarriage may have. So an initial study, and this was published in 2018, showed that miscarriage has a huge psychological impact for many women. And they found that in up to 15% of women, they can suffer deep depression lasting up to 4 months after that miscarriage. And that depression and feeling of loss was comparable in nature and intensity to grief reactions from people suffering other types of major loss. So it found that 4 in 10 women experience post-traumatic stress at some level. So, this is a huge amount of impact, psychological impact with each miscarriage. This work was then followed up, particularly around the post-traumatic stress, and found that when they analysed a huge number of women, this was 1,500 women that they interviewed, that a huge number of these women, and again up to 4 out of 10 women, suffer post-traumatic stress, anxiety and depression after miscarriage. Yes, it declines over time, but it can remain at clinically important levels for at least 9 months. So if we're considering a patient who's had an embryo transfer, they have got pregnant, their hopes are soaring, they then have a miscarriage, that miscarriage will live with them for many, many months potentially, and may in fact delay or in fact stop them having any future transfers, just to avoid the risk and the heartache that a miscarriage can cause. So this is, to be completely open and honest, this is why PGT-A was first considered to be a potential tool in embryo screening. If we could find the embryos that carried these autosomal or sex chromosome abnormalities before you transferred them, then you could theoretically reduce a lot of the embryo transfers that would ultimately lead to a failure to implant or these miscarriages. And so PGT-A as a technology, as a test, as a screening test, that assesses the embryo's chromosomal health, i.e. it looks at the embryo and tries to establish if it has the expected amount of chromosomal content, your genome. It then informs the transfer decision, so it identifies the embryos most likely to lead to a healthy pregnancy. It cannot guarantee a healthy pregnancy, but it can increase the chances of that embryo transfer resulting in a healthy pregnancy. And by doing that, we can improve the IVF outcomes for patients. So how does it work? Well, you should have a euploid embryo. Now, a euploid embryo is an embryo which contains the correct number of chromosomes. And these we know have the highest likelihood of success. So as I was stating earlier, both male and female have chromosome pairs 1 to 22. So these are your autosomal chromosomes. And then if you're a female, you have 2 copies of X. And if you're a male, you have 1 X or 1 Y. So what we're testing for is to find the embryos which look good and are euploid. What we want to test for also and try and screen out are the chromosomes which are aneuploid, the embryos which contain aneuploidy and aneuploid chromosomes. So in this case, we've highlighted chromosome 10 as a trisomy. And the reason that we've gone for chromosome 10 is that there has been no recorded live birth of anybody in the world with a trisomy chromosome 10. And what this tells us is that if you find an embryo with a trisomy 10, the chances of that actually resulting in a successful pregnancy is incredibly low. And so we're trying to ensure that these embryos are found before transfer. But what we know not just about chromosome 10, but any chromosomal aneuploidy in an embryo, the most likely outcome is either a failed implantation, so you don't even get pregnant. If you are fortunate enough to get pregnant, then the vast majority will miscarry, and some of those can be quite late miscarriages depending on the chromosomes. Or if it does go to term and a live birth, then that child is at a much increased risk of some form of genetic disease. I did touch on this earlier on in the chart, but didn't really go into it. But we do have these potential to find mosaic embryos where it is a mixture of both euploid and aneuploid cells. And we know that mosaic embryos implant less, they miscarry more, but can sometimes lead to a live birth. So PGT-A will also very much identify these embryos. And if you want to learn more about mosaicism, then please find the webinar on the impact and what we know about mosaicism. It's a great webinar, and it would tell you more about how mosaic embryos and the outcome of those mosaic embryos. So what is the evidence for PGT-A in the risk of reducing miscarriage? So obviously everybody would like to reduce miscarriage where they can. Now, there have been many clinical trials, controlled trials over the years, which have used an array of technology. And most of them have shown a reduction in miscarriage. So where you see a down arrow MR, that is showing that study showed that, excuse me, that the PGT-A reduced miscarriage. And the vast majority of those clinical trials show this. So what other people have done to try and bulk the numbers is do a meta-analysis. So that's where you group all the papers and pull all the data together. And the ones which use today's technology or closest to, so the Chen et al. And Dadu at the bottom, these all show a decrease in miscarriage rate. So the expected increase in implantation rate, the increase in clinical pregnancy rate, but today what we're really looking at is a decrease in miscarriage rate and how PGT-A can help that. Obviously, a lot of IVF data is generated through observational data, both across groups but also within a single clinic, and this is a single clinic study. So these were for the advanced maternal age, so the above 35, they had an average age of about 38. But what they found is a clinical miscarriage rate of under 10% in patients who are over average age of 38. But the other thing, which again we're not really talking too much about today, but miscarriage was not affected by embryo morphology in their study. So a lot of work and effort is put into grading embryos on morphology with the aim of using that to predict the outcome of the embryo. And for sure, there is some variance in that, but the key driver in this study showed that it was actually not the morphology, but the genomic competence or the euploid status of these embryos, which was most critical in reducing miscarriage. This is more internal observational data from a clinic, and what they did was they took in patients and they offered all their patients PGT-A who wanted it. And what they found is the expected implantation rate maintained very high across all patient age range if you found a euploid, and their miscarriage rate, so their sustained pregnancy rate, was also remained very high, showing a very low miscarriage rate. Now, of course, if you do PGT-A, you are reducing the number of embryos available for transfer because you're taking those which are aneuploid out of the pool. And so what you actually have as the patient ages, and this would be true for any patient, whether you do PGT-A or not, is you do start to reduce the number of live births per cycle started. That is just a natural fact of the patient aging and nothing to do with the PGT-A at all. This is another paper where they've been running PGT-A for many years, and they tracked the performance of PGT-A over 4 years worth of testing. And what they found is that the PGT-A group had a miscarriage rate of less than half their control group. So it dropped to overall across all patients to 4.4% versus their untested patients of 12.9%. And so this was a significant finding, statistically significant, and just to be clear, they scored their spontaneous abortion rate as the loss of cardiac activity. So the pregnancy had to get at least as far as detectable heartbeat. So this is actually a clinical trial. It was run on polar bodies, taking polar body 1 and 2. So this is just looking at the maternal contribution in advanced maternal age women. And what they found is no reduction in live birth rate, cumulative live birth rate per cycle started if you did PGT-A. What they did find is a halving of the miscarriage rate. And this doesn't even take into account the male factor. So again, a significant finding that if you do PGT-A, even on the polar bodies, which is the most expensive way of doing PGT-A, but by excluding those meiotic errors from the oocyte, you can actually halve your miscarriage rate. And this was a secondary finding in the clinical trial, and it was noted as being significant for the management of patients. This is another single study center. Sorry, this is another RCT, so a control trial, but this is done in a single center rather than multiple centers. Yes, it was a small group, but again, what they found is, and bearing in mind these were patients who were under 35, so your highest prognosis, lowest chance of miscarriage. In their control group, they had a miscarriage rate of 9%. If they did PGT-A, that dropped right down to 2.6%. So again, a massive reduction in the miscarriage if you screen out the embryos which are most likely to result in miscarriage due to being aneuploid before you transfer them. This is a big study that was a retrospective study, so this was plowing back through their data, so it's not a full clinical trial, but it was a retrospective cohort study, matched cohorts where possible. And what they found was that for women above 37 years of age, PGT-A was associated with a decreased odds of miscarriage, i.e. their chances of having a miscarriage was much, much reduced if those patients had had PGT-A. By decreasing miscarriage, of course, we increase our odds of a live birth. So if most of your pregnancies go on and don't miscarry, then you have a very good chance of a live birth. In this particular study, they were still doing multiple embryo transfers. So in the UK and many countries now, we still try and do single embryo transfer. However, they were putting back multiple embryos which have been screened by PGT-A, and they did find an increase in multiple live births. So what I want to talk to you about now is the SART data. So SART is the US database for the Society for Assisted Reproductive Technology, and they gather data from approximately 90 to 95% of all the IVF clinics in the USA and accumulate data over all cycles, all clinics over all years. Now, what we have done is we have looked at this data from 2014 onwards, and we've chosen 2014 specifically because the vast majority of these were then trophectoderm biopsy, so very similar to what we would practice today. They were also the vast majority run on the newer technologies of NGS. So as comparable as to what we're running today as we could find. And what we find with this huge data set, and this was over nearly 450,000 cycles, of which 120,000 were PGT-A, is that PGT-A massively reduces your miscarriage rate as the maternal age increases. So in the blue bars, the untested, we have the expected and seen in both natural and IVF increase in miscarriage rate as the maternal age increases. If we test first before we transfer those embryos, we have managed to maintain a pretty low level of miscarriage. Yes, it increases slightly with age, but we're maintaining a level which is comparable to the under 35s, which is a great message that if you have PGT-A, you can basically reduce your risk of miscarriage back down to the background level of the under 35s. A finding of this data also shows that what ultimately a patient wants when they have IVF is a live birth, clearly. And they also want to go through as fewer procedures and embryo transfers as necessary to achieve that live birth. And so what we have here is showing that basically, if you do PGT-A, at least for the under 42s, you're around a 50% chance of a live birth per embryo transfer. If you don't do PGT-A, then you are transferring, by the time a patient reaches 38, basically 1 in 6 embryos will result in a live birth. So you're doing 5 or 6 embryo transfers for every live birth. If you do PGT-A, you're only doing 2 embryo transfers for live birth. So a huge reduction in the number of transfers required, and also a huge reduction in the number of miscarriages that you would see. And that plays out very nicely in the sense that by avoiding these miscarriages, by avoiding the trauma of failed transfers, actually patients with PGT-A have a higher cumulative live birth rate per cycle started. And this is because we believe they are going through and using only the good embryos. They are getting the good embryos earlier, and they're avoiding the traumatic events which cause people to stop IVF and pull out. So if you have PGT-A, you're only having the good embryos transferred. You have less psychological impact of failed transfers. You push through and you get this increase in live birth per retrieval. And that is, again, a great message for patients. The other aspect that PGT-A can lead, which is not just miscarriage, but one of the risks of any pregnancy, is preterm deliveries. So a preterm delivery puts a huge burden both medically on the hospitals, but also a huge increase in risk of that child succumbing before they achieve their potential. So what we have found with PGT-A is that actually you'll find that there is a reduction in these preterm deliveries. The embryos going in are better. They are generally single embryo transfers. So if you have twins, you have a higher risk of a preterm delivery as well. So PGT-A not only reduces miscarriage, but it can also reduce the likelihood of preterm deliveries and all of the health complications that can bring. And so in summary, I would just like to say that miscarriage is highly traumatic, and most of the studies, I've got to be honest, have looked at the traumatic impact of miscarriage in women. It is noted in many of the studies that men also suffer, quite often silently, but men will also suffer, and the partners suffer during a miscarriage, and should not be forgotten. We know that the major driver of miscarriage is chromosome aneuploidy. We know that PGT-A can detect those aneuploidies before you do the embryo transfer. And this has now been shown repeatedly across many studies and across many groups to show that PGT-A can mitigate against this age-related miscarriage risk. It can't eliminate it. There are other causes of miscarriage beyond chromosomal abnormalities, but we can certainly mitigate against this increasing miscarriage rate with age. And so overall, PGT-A has the power to reduce the emotional trauma and increase the chances of a successful live birth per cycle started for patients undergoing IVF, and particularly the older patients who are at this increased risk of miscarriage and the increased risk of multiple miscarriages without screening. So overall, I hope this presentation shows you the power that PGT-A can bring to your clinic and to your patients in reducing the risk of miscarriage. And if you have any questions, please feel free to contact either myself directly at David Chrimes at coopergenomics.com or our global support at coopergenomics.com, and we will answer any further questions that you have. So I thank you for your time, and I look forward to hearing from you soon. Thank you.